Today we are entering in the lockdown 5, but we are going to discuss what has happened in the last 2 months and 5 days, and it's a very important day of our life. We are going to recognize every opportunity which comes to us, and we are determined by your intention, purpose, and the skill today. People tend to romanticize the past and dream of the future. It leaves them caught between a past that controls them and the future that avoids them. So we are going to hear from all over India the stalwarts, and let's take charge. We have got stalwarts and the country's who's who in the field of endoscopy, in the field of IVF, in the field of infertility, in the field of high risk pregnancy, and these are the corona warriors which have come from all the parts of India. They are in AIMS, they are in Mumbai, they are in South India, they are in East of India, and we have today all of the stalwarts to share their experience, what they did in the last 2 months and 5 days of the national lockdown period, and how they intend to start their OPD in the coming days, and how they are going to start the routine gynae surgeries. They have got number of them who are there already. So I would like to tell you, I am your host, Dr. Niranjan Chavan. I am presently the professor in Sion Hospital and unit chief. I am catering to the largest slum area of Asia, that is Dharavi. I stay in a red zone, that is Andheri, and I travel every day back to my Sion Hospital, my alma mater, and I'm very proud that we are now presently the torch bearers in the country, and I thank all of you who support us during the crisis when the video was shared and where all of you are with us. So I thank all of you. Join with me. I would like to thank Sun Pharma in Inca, Sinora, and Spectra division to support this program. And I would like to thank from the bottom of my heart Dr. Rishma Pai, our president of Mumbai Obstetrics and Gynecological Society. And I would also like to thank Dr. Anaita Chauhan. She is our secretary of MOGS to be present with us. And we are going to have a lively program and sharing each our thoughts. And obviously, we are going to have the question and answer session with you. You have made us, and we are going to make you feel comfortable. I would like to display the next slide, and I would like to introduce my members who are going to join. Dr. J.B. Sharma. Who doesn't know Dr. J.B. Sharma? He is a pioneer in urogynecology and presently the chairman of the Urogynec Committee of FOXI. He is a professor in the All India Institute of Medical Sciences, New Delhi. He has got more than 270 publications in the index and non-index journals, and he is author of many textbooks, and he is going to share with us his experience of dealing with COVID patients and how he is going to manage them in future. Thank you so much, Dr. J.B. Sharma. We go to the next slide now. Please start sharing the slides. Dr. Bhaskar Pal is going to join us in next 25 minutes. We all know him. He is going to be an important person in discussing what is happening in West Bengal. He is the General Secretary of IIT and he is a consultant at Apollo Hospital, and he is the President-elect of Bengal Obstetric and Gynaec Society, Vice President of FOXI. Thank you so much for joining, and we will share his views with us. Dr. Anaita Chauhan, we all know her. She's the Secretary of MOGS, consultant at Saifi Elizabeth Hospital, and she is presently also on the Journal of Obstetrics and Gynecology of India as the second joint editor. She has got numerous publications to her credit, and her field of interest is high-risk obstetrics, adolescent health, contraception, urogynecology. Welcome, Dr. Anaita. Thank you. Dr. Rajendra Sangpar, who doesn't know him? He is presently the treasurer of MOGS, and we all know he is the past president of IAG and the honorary secretary general of MOGS 2018-2020. He is a world famous gynecologic endoscopic surgeon based in Mumbai, attached to Hinduja, Hiranandani and Reliance Foundation. And he is my very good friend. All of you are my friends, but he is very close to me. Thank you so much, Dr. Rajendra, today to join with us and share your thoughts on endoscopy. Thank you. And we have the last of the best, Dr. Fessy Lewis. He is at Amrita Institute of Medical Sciences in Kochi. He is the head of reproductive medicine and is the Foxy Vice President elect 2021. He is also the Secretary Kerala chapter of ISAR and has got many publications and also received many awards, example like Foxy Korean Award, and he is going to share with us about his experience in infertility, IVF and IUI. So welcome all of you, and I would like to start the session now with Dr. Rajendra Sangpar to share his experience of endoscopy. I request you to please unmute your mic and join all of us. Thank you so much, Dr. Rajendra.
Am I audible?
Yes, you're audible, Dr. Rajendra. You've got 7 minutes. Please go ahead. Share your vision. Okay. How to start OPD and Gynaec surgeries, endoscopic surgeries in the near future, and what you did in the past. Fantastic. Thank you.
Yeah. First of all, I would like to thank Niranjan and the Mumbai OBGYN Society for giving me the chance to be on the panel. You know, if we say in last 2 months, what figures we have been getting every day, every person I'm sure is on television to see what is happening in the world as well as what is happening in Mumbai. Mumbai, the number of cases have been increased, and as a healthcare personnel, we have been facing more and more number of patients, and there has been a little anxiousness, or I would say a fear psychosis amongst the doctors. I know because of our situation is created, and we keep hearing about the demise of our colleagues, and they have been suffering about getting infected. So we have been affected by unknown contacts who have been seen by them as patients, you know. So first of all, everybody, as far as OPDs are concerned, what in last 2 months I've been practicing, majority of the times I was just only sitting in the hospital, my hospital, that is Sage Hospital in Malad, and doing nothing. I was just on computer searching about everything. But we, initial first month, we kept our OPDs on the hospital open for 3 times a week, just to cater to a telemedicine and WhatsApp appointments and discussion to the patients, and then cleaning the hospital and maintaining our operation theater. That's all. So as far as the my experiences last 2 months are concerned, I have done almost 7 surgeries laparoscopic, and that too only emergency cases, such as you know, the ectopic ruptured ectopics, the impending ruptured ectopics, the adnexal torsion, the malignancies such as ovarian malignancies, which we did, and postmenopausal bleeding, the DNCs and endometrial biopsies, and an incomplete abortion. I also cater to, you know, second trimester abortion for, you know, chromosomal abnormality at 16, 17 weeks of gestation. So all those patients I did see, but there was used to be a fear amongst me and my colleague about acquiring the infection. But at the same time, we did all these patients coronavirus test, which was earlier was prohibited by our municipality, and their guidelines were not very clear, and I used to get scared to prescribe COVID tests sincerely, and I used to inquire with my colleagues about many things, what will happen, what will go wrong, and then only I prescribed this test preoperatively. Now it has been clear that we must do by patients who need surgical admission or admission to the hospital, and if the person can wait, or the patient's surgery can be prolonged for 48 hours, we can able to do a coronavirus test by various labs recommended by the government. As far as in OPDs, precautions to be taken, that I think somebody would guide on, because I don't want to waste the 4 or 5 minutes of my important talk about laparoscopy and the guidelines for laparoscopy. If I get time, I will enumerate other things also. As far as laparoscopy is concerned, gynecological laparoscopy, these are the only cases which I cater in last 2 months. But in current, COVID-19 pandemic, whether to perform gynecological surgeries, whether open surgeries or a laparoscopic surgery, that we are also in dilemma. Currently, patients are calling us to take appointment for surgeries, but I'm just delaying my decision because I'm not very clear to start elective surgeries. The worldwide dictum is to avoid all planned surgeries, whether laparoscopy or laparoscopy in any given field. You treat the patient medically, or as far as if the situation is allowing. In all WhatsApp communication, laparoscopy practice have been put in a controversy and a scary situation because of certain reasons. One is laparoscopic surgery, require general anesthesia, and that is putting our colleagues and the healthcare personnel at a risk of having exposed to aerosols. At this moment of time, we must consider every patient who comes, whether tested or not tested, as a potential positive patient, and we should treat them as if like an universal precaution. So laparoscopy is put at risk because of aerosol for contamination and an exposure of the virus to healthcare workers, more to our anesthesiology colleagues because of general anesthesia, and it is also because of the insufflation of the abdomen with the pressure and having a head low and inflating the peritoneal cavity. At the same time, we must realize there are benefits of age-old laparoscopy, and we've been practicing laparoscopy since its inception into clinical practice in 1970s. So we are pretty much sure about benefits of laparoscopy, such as short hospital stay, quick recovery, and less pain, less morbidity, and early return to work. All of these, so we should, but at the same time, we should take care of ourselves and our healthcare personnel. What precautions I am following? That one dictum is elective surgery should be strictly avoided during this pandemic, or till the load of the pandemic has been getting reduced, and deferred all these surgeries for a later stage. A surgeon should, that is one more, we have a practice of going all around and doing laparoscopic surgeries at various multiple places, but I would say a surgeon should avoid operating at multiple centers and restrict himself to a single center, only to avoid cross contamination, because if a surgeon comes positive, he must have had visited many places. All those people would be in quarantine, and the hospital would have take care for minimum 48 hours shutting down. So that is important. So I think at this moment of time, a surgeon should avoid going to multiple places unless the place is following a complete guidelines laid by the microbiology department and the director of the hospital. All this is possible in major hospitals. And laparoscopy should be performed in emergency surgeries. And what are these surgeries which I mentioned are ectopic pregnancies, acute torsion of the cyst, or oncosurgery, because the staging would change if you avoid doing oncosurgery. Say, for example, early CS cervix, ovarian malignancy stage 1, all these surgeries should be severe abnormal uterine bleeding, leading to anemia, postmenopausal bleeding, require endometrial biopsy. All these things should be considered as an emergency procedure requiring them. They can undergo laparoscopy with due precautions. Of course, I did not do any surgery for laparoscopy of COVID positive patients. I did not have opportunity. I had no laparoscopy for COVID positive patients, for the prognosis of patient will worsen. If requires, she is for open surgery. Screening protocols, every hospital, when patient enters, you take history related to COVID, exposure, cough, cold, fever, and exposure to COVID in nearby areas. all patients should be given masks. We give masks to these patients, hand gloves from our side, and a sanitizer bottle to all these patients, so that continuously they can be under vigilance. All our healthcare personnel were wearing masks, plastic apron, gloves for sincerely, OT protocols. Fortunately, in my hospital, my operation theater is having HEPA filters, and I am thankful to my wife. She suggested me when we prepared the hospital. It has all got air handling unit with a HEPA filter, which can screen or filter 0.3 micron micrometer of the virus particles, and it has got a fresh air flow at 20 cycles. So in the OT, only anesthetist and required personnel should be present at the time of anesthesia, at the induction of anesthesia. And probably, the minimum number of people should be inside the operation theater. We have kept, one more thing is outside, we have a door mat, which is soaked in, the 1% sodium hypochlorite solution. And there is a sterilizer or a disinfectant at the OT entrance. So the legs or feet are being cleaned. For anesthetist, we have made a changing room. For me, I take out the operation theater clothes, scrub clothes, and change in my consulting room, just to avoid small room, many people entering. My staff changes in a different room. So these are things should be employed. Then inside the operation theater, only minimum number of patients. I operate from the right side, so I myself, the scrub nurse and assistant and OT assistant, and the anesthesiologist. So at a time we have 4 or 5 people in the operation theater. Number of people should be reduced in laparoscopy as well as in any operation laparotomy as well. When you are giving GA, we are using a full plastic cover. We are using all PPA, that is apart. PPA includes, all those which have been, everybody is aware of what is PPA. I don't want to go in detail, but we are using PPA. But as far as goggles, face shield, N95 mask, and another mask, 3-layer mask, surgical mask covering that, and a face shield, maybe a stud helmet or in a visor. And then we are using gloves, of course. All our healthcare personnel, we are using plastic cover which covers the patient's chest and the head, and we are doing intubation. As far as laparoscopy is concerned, the use of sterile camera cover is mandatory, and we use the anesthesia machine. They have a filters called CMEF viral filters. They can filter the virus as low as 0.3 microns. We use one filter at the endotracheal tube and 2 filters at the anesthesia machine ventilator side, so that there is triple check on or 2 times check of the air exiting from the anesthesia machine and the exhaled air going into the anesthesia machine. That's how it is protecting my anesthesia machine as well. That is what we did in laparoscopy. As far as laparoscopy is concerned, we use direct trocar entry, no insufflation in the beginning, because there is a chance when you put a Veris needle, take out a Veris needle, you put direct and trocar inside, there is a likely chance that you may have an escape of gas. I've been taught all the way from my beginning to use direct trocar, so I use direct trocar entry. 2 is I use a low pressure between 10 and 12 millimeters of mercury intra-abdominal pressure and take smaller incisions as far as the putting the trocars are concerned to avoid leak. That is I am doing. I'm using all the time bipolar. All ultrasonic energy source, they produce larger particles and a larger viral load. Now the controversy is some articles are saying that peritoneal fluid has got a more viral load. I am not sure. We must understand, we are learning from all these experiences from limited papers from international, and we should put our logic, because the virus is mostly in the lungs, spread by the nasal and all droplets. I don't think so that would be a very much load in the peritoneal cavity. I'm not very much I don't I think so that there is high concentration. There are some articles which are saying now there is no much of a peritoneal load inside the peritoneal cavity of a virus. But at the same time, we should take care. So low insufflation pressure, smaller incisions for trocar cannula, and we use again a extension tubing of 100 millimeter, what you get for IV sets, and we attach a filter that is called HMEF filter, viral filters to that, and that filter again attached to a suction tubing, that is our routine suction tubing, and it goes to the suction bottle. The suction bottle is half filled or 1/3 filled with 1% hypochlorite solution. 1% is to be prepared by a 1 liter of solution and plus 9 liters of water, and that is 1% solution. We fill the suction bottle with the 1/3 part of the 1/3 part has been filled with the hypochlorite solution, and we suck the partially open the outlet when we are doing laparoscopic surgery. So at every time the gas has been sucked into that bottle and getting filtered through the 1% hypochlorite solution. Surgery has to be first, thought over, and minimum surgical time should be there. So exposure to our healthcare workers and nurses would be very less. There are some passive filters which I have not used, such as Paul filters, and you must have come across with WhatsApp communication. So surgery minimum cautery I use, such as only bipolar, no ultrasonic at this moment of time, and the specimen delivery is a more critical part of the situation. Whatever said and done, say for example, ectopic pregnancy I wanted to remove, you can remove, you have to deflate the abdomen and then remove. It is difficult to locate the pathology inside the abdomen. If you are inflating the abdomen and then you are removing the pathology, then you are putting an endo bag, and that causes leakage of the gas in the atmosphere. So, that is the problem with specimen reduction. If you are doing some major surgery, such as I have not done any hysterectomy at this moment, but if you are doing hysterectomy, I would say, okay, at the end of the hysterectomy, either you remove the gas and remove specimen from the vagina, or you take a small mini laparotomy incision and remove the specimen. But at this moment of time, removal of the ovarian cyst, removal of the ectopic sac, and removal of the cyst wall lining, in one case, it was little difficulty because I remove it either endobag or directly with the trocar, with the overmolding forceps from the right lower port. It requires to be extended to 2 centimeters, and that causes leakage of gas. So it is a part of the surgery, but we have taken.
Thank you.
Sorry.
Thank you, Dr. Rajendra Sangpar. We will come back to you. Beautifully, you have explained the procedures, the amount of liters of gas, how to retrieve the specimen, and what cases you are doing, and how are you going to plan him in the future. We have got many questions lined to you, but we'll come back to you. Thank you, Dr. Rajendra. Wonderfully explained and very nicely in your typical systematic words. And thank you so much. I can give you still 1 minute if you want to complete. No issues.
Okay, I will finish in 1 minute.
Thank you.
So post-operatively, the important thing is fumigation in between the 2 cases. We use again Virkon solution, to clean and wipe out the operation theater. That is one. The passage has been cleaned by a fumigator. We bought a farm side, the big container of 16 liters, and you can spray the 1% hypochlorite all over, keep it for 15 minutes and then clean. That is all the time patient is wearing mask in the ward, and all the instruments are soaked in 1% hypochlorite solution for 30 minutes, including all my telescope. Telescope I don't put it, but other hand instruments. Points to remember that all time the personal protective equipments, what everybody knows, should be used, including the face visor and the glass, and risk of transmission is there, whatever you take care. And but at the same time, I would say laparoscopy has got definite benefits, to the sinus, when you have to judge whether the patient is really require laparoscopy, really requires emergency. But at this moment of time, emergency surgeries can be performed laparoscopy with due precautions. Future, I think the guidelines will become simple, and we are supposed to live with the corona. So we will do some I mean, I'm sure with all our colleagues and myself, we will find out some guidelines how to clinically practice. And but at this moment of time, the dictum is to do more open surgeries than a laparoscopic surgeries. But it may change again. So take care, wear mask, PPs, and do a safe practice. One more thing I want to show, just to mention in a few seconds. You have to be very careful about yourselves and your friends. I had an experience that my colleague visited my hospital, and we were chatting and having a cup of tea. Otherwise, all the time I wear a mask. And after 2 days, he calls me I gave an appointment to him. He says, Ares, I'm sorry, I'm having fever. I'm corona positive. So I got scared, and I am sitting in the hospital for last 5 days, doing nothing, staying in the hospital away from my family. I go only for a dinner. And so you have to remember, when you are taking no tea, no coffee, offering to your consulting room to your colleagues. I mean, it may be harsh, but take care. If your colleague as a friend is not wearing mask and talking to you, probably he may spread 3,000 virus particles or droplets in 5 minutes. So you have to carefully, tackle this situation. So that would be just a guidance.
Thank you.
Thank you so much for giving me this opportunity to talk. I can't hear. Niranjan, you are on mute.
Niranjan, I'm so happy to hear from you, Rajendra. And though we are not physically meeting in MOGS, Anaita, but still we are connected with each other every second, third week. We are on Zoom meetings, and I am very happy that MOGS has come out now with this wonderful webinar, and we are having a wonderful insight by you. Thank you so much for sharing. Now, we would like to go to Dr. J.B. Sharma. Dr. J.B. Sharma is a professor in All India Institute of Medical Sciences, and the credit goes to AIMS to do the first delivery and the first cesarean section. And he is a very good friend of mine. I know him since year 2000. And his email ID is also jbsharma2000. So I cannot forget that email ID. And thank you, sir, for giving your valuable time. I know you are a corona warrior, and Delhi is also still a red zone. So we want to hear from you. We have got 950 users logged in from India. And I would yes. And it's not only India, but from Nepal, from Bangladesh. There are members who are very good listeners, and they listen to us. I would also welcome Dr. Bhaskar Pal. I am really appreciating him that he has joined us, from his car.
No, I'm switching on my laptops now.
Yes, so I am very happy to see the dedication and dhamaka which you have made today, the sincerity, the Indian doctors who have come and log in from any corner of the India and Southeast Asia, whether they are in work or whether they are traveling. This is the commitment which you all have made. But please remember, if you are driving a car or if you are seeing this live webinar, be safe, and you can have the video recording later on, but be safe and drive carefully. And I welcome now Dr. J.B. Sharma to please share his thoughts, how he would manage the near future cases and the Gynaec surgery and what he did in the last 2 months. Thank you.
Oh, thank you very much, sir. Can you hear me?
Yes, we can hear you, sir.
Okay. Yeah, thank you, Dr. Niranjan Chavana, great friend of mine, and doing so well for the whole country. Actually, I'm really proud of you, sir, and of ma'am Komal. Convey my regards to her. And all the esteemed members, please, I regards, including Bhaskar Pal. Yeah, so thank you very much, sir. And Dr. Sangpal has very nicely highlighted everything. I think he has made our life a lot easier. So as far as like in AIMS, I'll just try to highlight how we started in AIMS, for the first case we did of cesarean section, and now also we are planning and what we are exactly doing. So the minute like our Honorable Prime Minister started lockdown, so we followed that immediately. We stopped our routine OPD immediately, but our obstetrics you cannot stop. So obstetrics kept on coming. So we did some cesarean on initially on non-COVID patients, but still we were at the same time what we did triaging, sir. So we converted our normal labor room was non-COVID labor room, and then we had our AIMS trauma center was converted into COVID hospital. So any positive COVID patient was taken there. Now problem was that we had another set of patients who were suspected patients. So our OPD was stopped closed. So we converted our OPD gynae OPD into suspected COVID patients. So now we had three types of patients. Pure COVID will go to COVID hospital. Non-COVID will come to our normal labor room and normal antenatal. And suspected patients or whose status was not known, they would go to that suspected area. So in fact, the first case was done in that suspected area, and that was the wife of one of our own doctors who turned out to be positive. And then that was converted. So all precautions were taken, and that is was the first case and all. So now during this time, I mean, I was doing more of non-COVID patients, and like as a senior consultant, so we have got 3-tier system now. We have got junior agent, senior agent, then we have got assistant professor level, and then mediocre level, and the 3rd-tier system. So as 58 plus, we are 3rd on call. Only for high risk patients. Like day before yesterday, I went for a case that we did. That was a Manchester case, and old patient of Manchester, but she came with the hematometra. So only emergency cases we are doing. So in this case, we still did COVID test for that, sir. So any gynae surgery which we are doing now, we are doing COVID test on them unless they are acute emergency like ruptured ectopic patient in shock. That's the only this thing. Otherwise, in that then we take all the precautions. So in this patient, day before yesterday, we took that case. So we took that into non-COVID OT because the COVID test was negative for her. But still, we used all the precautions. I used gum boots. We used the face shield, we used N95 mask, and we used non-porous gloves. But of course, we didn't use full PPE because he was a proven negative patient. And same way, assistant, I had just one assistant with me. Normally, we would have 2 or 3. And in anesthetist also, there was like one and another one sitting outside and one attendant. That's it. So we did that case like that. And similarly, I did another case which was like placenta. That was scar ectopic pregnancy going into the bladder. So that case we did again. For that case, he was stable. So we first did COVID test on her, and once COVID was negative, so we waited for 1 day. Next day we did her. So same precaution we took. With that case, we took non-COVID area and this thing. But those patients who are COVID positive, then they are taken to our COVID center. There all precautions are done, and the full COVID team is there. 1 week team that is there. They do only COVID patient, and then they get 2 weeks off after that. So this is what we have done, and now what our plans are. Till now our OPD and routine OTs were suspended, but now gradually we have started teleconsultations already. So teleconsultation patient can log in and then take it, and then they are ringing us. I mean, usually we have posted like 1 GR, 1 SR in that every day. So they take all the calls and then they ring us consultant that okay, if they have any queries, and sometimes they make us to talk to the patients also, and some patients of course talk to us directly. So now we are planning to start OPD in the another setup, but we have asked. Normally we used to see 100 patients in a day. Now we are limiting it to 30. And that also patient cannot come directly. And now we have started triaging areas. Sir, all like basically in the triaging area outside we have 1 GR, 1 SR, and 1 social worker. They sit in full PPE. Full PPE, they sit, and then there is a sanitizer there. Any patient coming cannot come directly in OT labor room anywhere near us. So they go to that triaging area, and then they are asked history. Are they from the hot spot area? Are they have any symptoms? Are they related to exposure, heavy fever, anything? And temperature testing is also done. So only those who are negative, then they are allowed inside the OPD. Okay, and those who are positive are taken to the COVID separate hospital, and those who are suspected, then we do test on them, and then only they are allowed in. So they cannot come inside directly. They cannot walk in. So that this is what we are planning our OPD like. Till now only consultation, teleconsultation, but we are planning to start only like from 100 only to 30. Those also who like on teleconsultation, what we are finding that they need to come in. Until now, we are just we have started limited surgery and laparoscopy surgery. Till now, we are not doing. Dr. Sankpal has highlighted that. But we will, and we are trying to do all cases under spinal anesthesia because general anesthesia on suspected COVID patient because a very, very high risk aerosol generating apparatus basically. And we are doing on all patients basically COVID testing, unless I'm an acute emergency patient like ruptured ectopic patient in shock. Those are the only exceptions. Otherwise, we are doing just routine like we were doing HBS antigen, HIV testing. So now we are doing COVID testing on them. So this is what we are planning, sir. Thank you very much.
Thank you, Dr. J.B. Sharma. So nicely you have explained what things you are doing, and really admire your courage of doing so many cases in Delhi. Mumbai and Delhi are facing the same situation.
Absolutely, yes.
Hope this goes away as soon as possible. And I think we don't have to panic, and we have to be very cautious, have social distancing. What I find is that during lunchtime, we should not even come and talk to each other, or for that matter, we share our dabbas and sit together and eat. So this
yeah,
has to be
absolutely. We have not
avoided.
visited our room for 1 month. So that faculty room where we used to share lunch, we don't go there anymore.
So please, these are very small things. Try to avoid sharing those small, chapati and some dabba and bhaji and exchanging, because that is going to be a vulnerable point in your life, and you will take back home that corona. So I do hope that message is given, apart from taking the care for the doctors. And I think resident doctors are very naughty, they are very smart. They feel they are young and they are enjoying this life, because this is once in 100 years. A pandemic comes in our lives, and everybody wants to do the best of time and get the best things. But still, I feel that you have to maintain some social distancing. They celebrate birthdays, they celebrate cake cutting, they celebrate Eid, and they cut, cakes and biryani. So I think that is to be controlled.
That must be.
We have to just postpone all these things, and maybe the small things, because see, one day or the other we are going to get COVID, or probably may not, but we just have to procrastinate it and push it further so that we don't land up in any situation. Right now, one of my own lecturer is COVID positive, and I'm understanding this situation. 2 lecturers of mine are there. One lady is now positive, and there are 6 residents who have come positive. So my resident is now shifted to that unit to work, and one more of my unit resident has got shifted to another unit. So I just got, instead of 4 housemates, I got only 2 housemates. And the issue came because they celebrated birthday. I'm not trying to say that they are wrong or something. Maybe the reason could be anything. But unfortunately, they were all staying together. We are having shortage of issues of rooms. So they were sharing the room. It was just a small affair, but all of them turned out to be positive. And we are having a big load of COVID positive. So please, all these small things are very important. Try to be maintaining social distancing. Be Atma Nirbhar. And I now request Dr. Bhaskar Pal, the man from Bengal, the Bengal tiger of Foxy. He has joined us, and he is going to give us the insight from West Bengal, his determination to be live through his car and now resuming services post-COVID. Bhaskar, the mic is yours. Please join. Thank you.
Thank you. Am I audible?
Yes, you are audible.
Yeah. Is my screen seen?
Yes, our screen and audio is the best in the world. You will never find any hitches or glitches.
All right. Let me start by thanking Dr. Niranjan Chauhan, whose TRPs as a moderator is at an all-time high. And I'm disappointed to hear it is 950, because with Niranjan around, I always expect it to be in thousands. So by the time we finish, I'm sure that it will cross 1,000, because Niranjan has been giving numbers like 2,000, 3,000, etc. And it's a pleasure to be on Niranjan's panel. Now, Niranjan had suggested that Anahita and me speak on OBS and Gynaec services, how we are resuming services, and what is our personal experience. So I thought I will put forward approximately 5-6 slides just to say how things are. Now, in Calcutta, the situation is slightly better than Mumbai. As of end of May, we have a limited community transmission, and we were increasing by around 200 cases a day. West Bengal at one point of time was not allowing us to test anybody, and now, unfortunately, we have one of the most liberal testing policies in the country. However, we've seen a sudden spurt of cases in the past 3 days, which is possibly because of the migration, and we expect this to worsen because of the recent cyclone that we've had, because 5 lakh people are all even now in shelters. However, because the situation was not so bad, on the 4th of May, the government of West Bengal directed the hospitals to resume other services other than emergencies as well. So officially, we resumed our OPD services from the 4th of May. However, even now the footfalls are low. Probably there are 2 reasons: because transport is not widely available because of the lockdown issues, and also people are scared to come to the hospital if they can avoid it. Elective surgeries have started, but there are very few elective surgeries. These are essentially semi-emergency services where patients really cannot, a fibroid with bleeding or with an ovarian cyst with pain. What has really taken off is video consultations have taken off hugely. I have just looked at my data of May. I have done around 60 video consultations, and only one of them I had to tell that please come to the hospital because I cannot solve your problem over the phone. But for seeing our follow-up patients who are endometriosis, who are polycystic ovarian disease, those who are post-hysterectomy, post-cesarean, most of the situations we can solve over a video consultation. How have we resumed our OPD services? Now, we have a screening with questionnaire at entry point, and the screening looks at where the patient is coming from. It looks at whether the patient has got any fever, cough, shortness of breath in the last 14 days. It also asks whether anybody in the family has got the same symptoms, whether anybody in the family has traveled outside the state or in a different district in the last 14 days. If the screening questionnaire is fine, then there is a thermal scan at the entrance. Only one relative is allowed with the patient. A surgical mask and not a cloth mask. A surgical mask is mandatory for the patient and the companion when they enter the hospital building. We see patients at the present moment strictly by appointment, which is a very culture shift for us because our outpatients used to remain open for anybody who walks in. In the waiting area, we have blocked off alternate chairs. Alternate chairs, we pasted paper saying that do not sit on this. So at least there would be some amount of distance in between 2 people when they sit in the OPD. What sort of protection do we wear in the OPD? As a hospital, we've defined what doctors and nurses need to wear in different settings. So as doctors wear an N95 and a surgical mask, which is possibly a overkill. Possibly in the outpatient only an N95 is sufficient. So the hospital wanted to err on the safer side. And along with that, they've recommended that we wear a goggles or a face shield. The patient and the relatives sit 3 to 4 feet away from the doctor. The consulting rooms are not big enough to make it 6 feet. We wear a wear-on and gloves if we examine the patients. If we touch the patient, we have to put a wear-on or a cloth gown and a set of gloves. On the top of the patient couch, on the top of the bed sheet, we put a paper roll, which is changed after every patient. We sanitize our hands before and after patient interaction. And in addition, we wash our hands with soap and water after every examination. And the surfaces are cleaned at regular intervals, approximately around 2 to 3 hours. What is our admission policy? All are, as we said, that at West Bengal at the present moment has got one of the most liberal testing policies. So all our planned surgeries get a pre-op RT-PCR for COVID-19 on an OPD basis. If a general anesthesia is planned, in addition, we do a low radiation HRCT of the chest. The patient is admitted only after these results come in. As Dr. JB said, that if it is an emergency, then what happens is patient only gets a screening CT chest. If the screening CT chest is suggestive of COVID, the patient is sent to a COVID hospital. If the CT chest is normal and an OT is not planned, for example, a urinary tract infection, then the patient is admitted on the wards. If a OT is planned, then in spite of the normal CT chest, the patient is admitted in an isolation ward and an RT-PCR is done the next morning. By next evening, when we get the results back, then the patient is shifted back to the ward. If there is a life-threatening emergency, for example, there's a ruptured ectopic of which we get more than our usual share these days, the patient is operated in the COVID OT and shifted to an isolation ward or isolation ICU pending the COVID test. Only after the COVID test comes, the patient is shifted back to a normal ward. In spite of COVID testing, because there is an issue with false negative rates of COVID-19 RT-PCR and HRCT test, we presume that all patients are positive. Hence, appropriate protection, which is a contact or droplet or aerosol protection, is required for all patients depending on which setting is it and what you are doing. And finally, hand washing and social distancing, even among our colleagues, is essential. More healthcare workers get infected from other healthcare workers rather than patients. That is exactly the point Rajendra was making. That is exactly the point Niranjan was making. And we need to remember that we cannot take off our masks when we are talking to our friends in the OT side room, for example. I will end with a PPE, and these are the PPEs that we've defined as an infection control team in our hospital. We've divided them into contact precautions, droplet precautions, and aerosol precautions. What is a contact precaution? Where your distance with the patient is more than 3 feet and you have no clinical interaction. For example, the front office staffs and etc. For them, we've defined that it is a surgical mask and gloves is appropriate. A droplet precaution is when you are seeing a patient inside your consulting room, which is less than 3 feet. There is a clinical interaction. You wear, as I said before, a mask, which is an N95 and a surgical mask. We wear gloves and a goggles of face shield. If we are examining the patient, then we put a wear-on or a cloth gown. Especially those who are doing an ultrasound, we need to understand that they will spend more than 15 minutes per patient. So it is absolutely mandatory they have a well-fitting goggles, and along with it, they either have a cloth gown or a disposable gown apart from their masks. Aerosol precautions, wherever a patient is getting nebulized or a patient is getting intubated, extubated. I'm not talking of operation theater because Rajendra has spoken in details. We need an N95 and a surgical mask. We need gloves. We need tight fitting goggles or a face shield and a waterproof full gown or a coverall, and along with a cap. Thank you. I'll be very happy to take any questions that come up. Thank you, Niranjan.
Thank you, Dr. Bhaskar, the tiger of Bengal, the Bengal tiger. Thank you so much. Now, I want to tell you one thing. You don't have to be disappointed because we have got 1,350 users registered.
That is what is expected. Thank you. Well done.
1,350 users registered, and that is because it's a Monday, the first day of lockdown 5.0, and everybody is busy opening their shutters, opening their doors, and opening their clinics, and they are all eager to hear. And we are very happy that we have got 1,350 users. Thank you, Bhaskar. I would like to tell that in our department also, last week the MCGM has given one thermometer, that is the infrared one. Then we have, along with that, a BP apparatus, a pulse oximeter to be given to each unit. So all units, I would like to thank our dean and the director who has given this to our department, so that obviously it is very less, but surely it will help us to detect any patient who has come with fever, cough and cold, and nicely explained what efforts you have done and the use of teleconsultation. And it's really nice to hear from you. We will come back. There are many questions. And now we go to Dr. Anaita Chauhan. She's going to tell her experience in Saifi Hospital, where she is a consultant, and how she has managed last 2 months, and presently what is going to do, what is going to be done in her clinic the next few months.
Thank you, Niranjan. And I agree with Bhaskar. You are now the king of the webinar. And it's indeed a pleasure on behalf of MOGS also to welcome you all today. I think the previous speakers have made my life very easy, and I don't want to repeat what they're saying. So what I thought I'd do is I'd first talk about what a small OPD practice could, a doctor in a small OPD practice could do to reopen the clinic. We are keeping on hearing things like new normal, etc., etc. I would like to start by saying that for the next few months, don't be impatient. Practice is not going to be the same at least till the end of the year. And especially to the junior colleagues, don't be too bold and take chances. At the same time, you have to continue your profession, which is serving the population of the country. So practice is not going to be the same. Don't expect or don't even want crowds in your OPD. Rather, OPD should be opened in a very controlled manner. Now, in the last 2 months, I agree with Bhaskar that the number of teleconsults have gone up tremendously. And one of the important documents, which is the Ministry of Health and Family Welfare's March document on telemedicine, has helped to guide us in our practice. An important point about telemedicine is that especially for the antenatal patients, we can replace the standard 7, 8, 9 or 10 visits with only 3 or 4 physical visits, and the remainder we can do with the telemedicine consultation. And this has really been what we've been practicing for the last couple of months. Bhaskar mentioned that person sitting in his OPD at a distance of 1 meter would only wear goggles or only wear a mask and gloves. And unfortunately, Bhaskar, the situation in Bombay is so bad that we are not going to take that chance. So one part I wanted to talk about was the telemedicine. The second part I wanted to talk about was in a small OPD or a consulting room, it may not be possible to take a detailed questionnaire from each patient regarding the history as she walks in, but it may be a good idea to keep a small register at the door where you can at least have her name, contact details, and the area from which she is coming, so that then you can contact or trace that patient if required. Obviously, government recommends self-declaration form, which may not be possible for smaller nursing homes or small practitioners. But at least if the patient has written in a register to say that I have come of my own free will and I do not have any issues, then that should be good enough. The second thing is, of course, social distancing in the consulting room. Keep in mind that most of our ANC patients require more hand-holding right now. So half your consultation will be on your antenatal problem and half your consultation will be explaining all the problems about COVID. So make sure that you give each patient enough time. So don't cram your appointments too close to each other. A good practice is to not see more than 8 to 10 patients in a single OPD session. Make sure that you have at least 5 or 10 minutes extra than your normal consultation to answer all the COVID related questions. Make sure you have that extra 5 minutes to have a quick turnaround in your consulting room to change the disposable sheet, to sanitize the surfaces. Bhaskar mentioned surface sanitization after every 2 to 3 hours. But currently in my practice, what I'm doing, though it is only consulting, I'm sanitizing in between each patient. I'm using a surface sanitizer, which is an aerosol, between each patient to clean. I'm not allowing patients to carry their files or put the files on the table. I'm actually looking at their reports, which they may have previously sent on email or WhatsApp, and I'm not allowing them to even put their files on the table. Only my prescription pad is handed over to them. My letter with the prescription is handed over to them. Patients, of course, have to wear masks as well as gloves. They have to sanitize at the entrance. An important point is that we have to do the same for all members of our team or our staff as we do for ourselves. Because getting staff to work in this situation is extremely difficult. Nursing staff, labor staff, etc. are all more terrified of this virus than we are. And they tend not to report for work. If you can assure them that their protection and their health will be taken care of, that's a very important point. If you are wearing a wear-on, they should be wearing a wear-on. If you are wearing a disposable gown in your consulting room, they should be wearing the disposable gown. Of course, the environmental burden of so many disposables is a topic for another day. But what we can do is, if we are using disposable gowns or disposable PPE, which may not be sterile, each of us can keep 3 or 4 sets. And after a particular OPD session, we can dip that either in a hypochlorite or another antiseptic solution, rinse it out and reuse it every 3rd or 4th day. This will, of course, reduce the burden financially, as well as we will be able to use the lot of disposables for all our staff. Another important point, which is to note, do not refuse MTP services. I think Rajendra did mention that his hospital also caters to second trimester, and do not deny MTP services to any patient. At the start of the lockdown, way back in the end of March, beginning of April, doctors were saying, wait for 1 week, wait for 10 days, come back. But now you cannot deny any MTP services. Another important point when you're counseling patients is you have to tell them that the BMC or the local authorities or the government is going to continuously change their protocols and their rules. And we as doctors have to obey their rules. So today I may say, don't do your COVID testing, and tomorrow I may say you have to do your COVID testing. So I think it's important to even appraise patients that they must be aware of the rules. A point which I want to mention, which may be a little bit, which we have seen in Bombay, which is not a pleasant point to raise, is that we are seeing COVID positive patients shopping for doctors. They are withholding their reports and they are shopping for doctors. Now, I guess this is a catch-22 situation because they may have gone somewhere previously and were refused care, and that's why they're going from pillar to post trying to find institutes or hospitals or nursing homes where doctors will attend to them. I think an important point from a personal front is that we are not insular. We each should have our own sounding board or our own colleague or our own friend who is in the profession who we can, talk to and discuss what we are going through on a day-to-day basis. So today I got this patient and this happened. We should have somebody who can take our back when we are in problems. And I think it's important to look also for the future of thinking about something like a group practice where I don't have to go to my clinic every day. I don't have to go to the hospital every day. I can function as a part of a team. I can have somebody else to take my back for me when I need it. I had just a couple more points to mention because Niranjan mentioned that I am at Saifi Hospital. Now, many of you may have read that many of the hospitals in Bombay, the large multi-central hospitals, one after the other had to close their doors or fell into disrepute in the newspapers because of COVID positive patients. And it's important for us to make sure that our patients understand, as Dr. JB said, that we have three clear areas. We have the COVID negative, we have the COVID suspect, and we have the COVID positives, which are going to be the case in all hospitals. No hospital can say today that I will not take a COVID positive patient or I will take only tested patients. So we have to have clear distinctions. We have to treat each and every patient as though she were COVID positive. In fact, in Saifi Hospital, even if the patient's COVID negative report is available, at the time of delivery or cesarean, we are using everything disposable, including the drapes on the patient, and we are all using full PPE. So I think depending on the situation or the circumstances where you're working, you have to be able to adapt. Another important point in some of the larger hospitals in Mumbai, that as you exit the OT complex or as you exit the COVID ward, you have a shower where you completely have a hot shower before getting into your street clothes and you exit. So I think these are some of the points that I wanted to mention. The rest of the points have already been covered, and I'm happy to take questions at the end of this. Thank you.
Thank you, Dr. Anahita. You have done very nice work and explained how you are managing your OPD, small OPD setup, how they are supposed to manage history taking, examination, and the surgeries. And I like the best point where you take a shower and then you wear your clothes. Obviously, I remember, and you have already told that in the beginning when COVID started, there was a very panic situation, especially when Hinduja Hospital was in news, Saifi Hospital was in news, and the BMC authorities came and immediately locked down. And I would like to share a bit of information to the audience across India, Nepal, Bangladesh, that Saifi Hospital is a world-class healthcare facility. It is located at Cherny Road, and it is overlooking the Arabian Sea, the Queen's Necklace, through which you can see. And it is basically the head of Dawoodi Bohra faith. That is, if I'm not mistaken, Sayyidina Muhammad Burhanuddin. He dedicated this hospital in the memory of his father, Sidna Tahir Saifuddin. So, Anahita, you are doing a wonderful job in your hospital. And
Can I say one more thing?
Yes.
because you did mention that in Sion Hospital and other public hospitals there is a shortage, I would like to go on record to say that MOGS has launched the MOGS We Care and Share program, where we are basically mobilizing all our resources in MOGS to donate large quantities of PPEs, N95s, infrared thermometers, blood pressure equipment, fetal Dopplers, etc., to all the major public hospitals, so that our residents and our faculty, who are all members of MOGS, can benefit and indirectly pass on the benefit to their patients. Thank you.
Yes, thank you. And we are very thankful to MOGS. I think very shortly in the next 1 week time, all the major hospital Gynaec departments will be receiving this whole contingency packets from the courier services. And we thank Dr. Ishma Pai, Dr. Anayata Chauhan, and the whole team of MOGS to dedicate this to the Corona warriors of Mumbai city. Thank you so much, Dr. Anayata, for that wonderful message which you gave. We will come back to you soon. And now we come to the South Indian guy, the man who is the president-elect of Foxy, VP, Vice President Foxy 2021. He is an associate professor and a senior consultant at Amrita Institute of Medical Sciences. He is none other than Dr. Fessy Lewis from Foxy, and he is the head of reproductive medicine. Today he is going to take us to the story of how to start IVF, IUI, and see your infertility patients. Dr. Fessy, the mic is yours. Please go ahead. You are the Manmutti of Kerala.
Okay. Once again, thanking you, Dr. Niranjan, for arranging this wonderful webinar, and also the MOGS for a good platform here. I think now my job has been made easier by the previous speakers. I think we have covered from all part of India, from the north, Dr. J.B. Sharma from the All Institute, from the west, Dr. Aneda and Dr. Rajendra Sangpal, and Rajendra Sangpal specifically covered about the laparoscopy part and the other gynec surgical importance. Dr. Aneda and Dr. Bhaskar covered about the routine obstetrics and other practices, and Bhaskar is telling from the east also. So from the south, I'll be covering basically from the Kerala aspect and also about the reproductive medicine aspect. And in fact, one of the first cases of the COVID was reported in Kerala from the 2 medical students who came down from Wuhan in the February beginning. And since we had a Nipah episode 2 years back, we were very vigilant and thorough screening of the patients, taking detailed history and thermal scan was started way back in February. And also more than that, contact tracing was very important and was happening here in Kerala. So I'll come back to those aspects and the last regarding the state. Regarding the reproductive medicine, I just want to tell a few things. This is one of the COVID-19 statement put forward by the American Society, European Society, and International Fertility Federation Societies. They tell the cost of delivering all forms of medical care during the pandemic will rise due to the demand for ancillary medical services and supplies, including appropriate personal protective equipments, additional testing, and other points of care measures. But reproductive medicine care is essential for the well-being of society and for sustaining birth rates at a time that many nations are experiencing declines. So they tell we can start the reproductive medicine treatment at this stage after the initial lockdown. But during pandemic, reproductive medicine professionals should continue to advocate for the well-being of the patients, monitor local conditions, including prevalence of disease, status of the government or state regulations, according to the availability of the sources, availability of the infection and prevalence at that place, implement proactive risk assessment within their practice, and prioritize care and judiciously allocate the use of limited resources and using the medical criteria, and counsel patient about all options, including deferring the evaluation and treatment. That is very important because it is not always emergency treatment. That's why initial few weeks we were restricted to follow up of only the patients who had conceived and had and follow up of that patients only. And adhere to active risk mitigation strategies to reduce the risk of viral transmission, develop clear and codified plans to ensure the ability to provide care while maximizing the safety of their patients and staff, remain informed and stay current regarding the new medical findings, develop or refine robust emergency plans, and be prepared to act at any time. And this is another guidelines by the British Fertility Societies and Association of Reproductive and Clinical Scientists, which they published in the 6th of the May, that tell 5 key points for that. Reception of the fertility services must take place in a manner that minimizes the chance of spread, and centers should ensure fair and transparent approach to any prioritization policy. They tell according there it is NHS must be according to that reducing burden, and patient considering treatment should be fully informed about the effect of ongoing pandemic on the treatment and give informed consent. Sometimes patients have come and asked the initial times of pandemic, okay, now I am free, I can travel by saying, go, I'm coming to the hospital, so why can't we do the IVF treatment? So we had to deny the patients at the initial time. And fertility sector should adopt sustainable changes in the working practices that help to build the resilience against any future increase in the spread of COVID-19 in the community. So basically it is three things: triaging, screening, and testing at 3 stages. That is before starting the treatment, during the treatment, and any action in the event of suspected COVID-19. These are the 3 things which we have to be very careful. And before starting this treatment, a screening questionnaire, especially I think detailed screening has to be done, especially in my center. Even it is a standalone unit under the Amrita Medical College, which is a separate building. So we can do the proper screening about the patients definitely coming to that. May not be possible in a big corporate setup sometimes. An antigen test, if available, according to the prevalence of the disease in that area, should be completed, and patient and donors with diagnosis COVID-19 infection should not start treatment until they have recovered. They are not considered infectious. National guidelines should be followed in this regard. Centers should be considered whether they advise patients and potential donors to self-isolate if possible from the start of ovarian stimulation treatment until egg collection. And during treatment, a corona screening questionnaire should be administered prior to every clinical visit. And patient and donors with the negative corona antigen test at the start of the treatment and who remain negative on questionnaire screening throughout should be allowed to complete treatment. In centers that institute an antigen testing policy, consideration should be given to performing a further antigen test as close to the as possible. That means if it takes 2 days, 48 hours or 72 hours before the ovum pickup. And if in any during that time, if any patient is suspected to have COVID-19 or positive, then we must avoid giving the trigger and ovum pickup to the patient after counseling the patient. In the event the patient is presenting with COVID or confirmed COVID-19 after ovulation trigger, a multidisciplinary individual risk assessment should take place, a balance on the risk of reframing from the oocyte retrieval against those proceeding. And at present, little data on the risk of minor surgical procedures in women with diagnosis of COVID-19 is available. So how do we minimize the risk, clinical risk? This to during the stimulation, if you are starting after everything, we must try to reduce the risk of OHSS. So in those patients suspected can go for hyperstimulation, we must go for an antagonist protocol and agonist trigger. And centers should bear in mind the value of these and of careful ovarian stimulation to minimize the risk of hospital admission for patient to reduce the burden. That is most important. And in the laboratory, the evidence there must be minimal risk of in the laboratory. Not only the staff, but we must be careful in handling as it is found to be droplet infection. Evidence to the date suggests that respiratory virus responsible for COVID is not present in follicular fluid or seminal plasma, or not associated with gamete and embryos. Even though one anecdotal study has come, it was found in the semen, but there is no other studies about that. And clinical layout, this is most important. Most of the cities where the IVF centers are small, before resumption of the fertility service, we must be careful to reassess the clinical setup, so that there won't be any social. Patients must not crowding the waiting area or in front of the OPD or the scan room. So we must give appointments selectively, so that only few patients will come. And as far as possible, do the consultations over the phone and minimal personal visit to the clinic. And bystanders must be minimal, no other associated bystanders. And even husband is coming, even for giving the semen, the visit must be very minimal as far as possible. Must come to the as minimal as possible. And if you have to restructure your waiting area, you must do that before starting, especially in a small clinical setup. And this is one interesting this thing got from the ASRM group, where what are the potential risk of each procedures of the infertility, and what are the precautions must be done by the staff, and in addition to the gloves and the mask, which is medical degree. For oocyte pickup, we must use the eye coverage, and or also the operative and laparoscopy procedure. We must be covering the eye coverage must be done, and that this is very important to each procedure, how we have to proceed when we start the reproductive medicine practice. And similarly, a joint IFS, Indian Fertility Society, Indian Society for Assisted Reproduction, the Association of Clinical Embryologists recommendation has been put up in the website. Anybody can go into the ISAR website, isarindia.net. In the first page itself, we can see that it is almost similar to that. And regarding our part, since about 10 days back, we had a whole week where we had days with 1 new cases or 2 new cases or 0 new cases also. In those, that is our the lockdown 3 phase. That is the time where we started our IVF stimulation protocol. But for last 7 to 10 days, we have been slightly increasing number of cases, because a lot of patients are coming from abroad, from those are in the Middle East or the Europe has been coming back. But here there is strict 7 days of institutional quarantine, and after that 14 days of home quarantine, with regularly people are coming from the health department monitoring that, and monitoring whether the patients are going out is occurring, and any suspected patients is being screened for the COVID PCR is being done by the state government. So the incidence is less, or at least was less till last 1 week. But we have to be a lot of things is not new to that, because some patients came from Middle East where tested for rapid testing was done at the airport, they were negative. But when they came here and it was suspected, after 1 day when they tested, just the next day itself they were positive. So we cannot tell about how this testing part, or you are still lot of things are not known to that. So we have to follow all the precautions, all the surgeries, everything the previous speakers, and whatever the guidelines about the reproductive medicine committees are being followed. So right now, initial part, when the incidents were very less, before starting the treatment, we were not doing. But when the cases increase, or when the incidence is more, that has to be confirmed to the facilities available, when we will get the result, how easily it can be done, and how the spread of the diseases according to that guidelines of that part of the state or part of the country, we have to follow before starting the fertility treatment in your area. Thank you for patient hearing.
Thank you, Dr. Facey. You have given nicely the whole guidelines, explaining how to manage your OPD, and before the treatment, during the treatment, and after treatment, what are the triage and what are the contingency plans you are going to go. So we start with the questions now. I would like to tell you all that we have got 1410 users logged in, and it's very nice, and they are very eager to hear from each of you as per your specialty, And we start with Dr. Rajendra. Dr. Rajendra Sangpai, I request you to please unmute your mic. And we have got congratulatory messages from various parts of the country. Especially, I would like to specifically tell you, Dr. Gracie Thomas from Kochi. She has said, congratulations, Dr. Niranjan, and to all the participants who have done a wonderful job for this webinar. Okay, so Dr. Rajendra, are you listening to me?
Yes, am I audible?
Yes. You are very much audible, and your presentation was excellent. You gave all the practical tips, and basically they are asking you when to start HSG, when to start endoscopic surgery, should we get a COVID test before routine gynae surgery. This lady is Dr. Ruby Bhatia, professor and HOD from MMIMSR, Maulana Ambala, Haryana. Dr. Ruby Bhatia's question.
I think regarding the hysteroscopy and laparoscopy, we must, since the patient is having general anesthesia, we must or entering into the theater, and we must definitely look into the COVID testing, preferably within 48 or 72 hours before the procedures, and then only we must do it.
Dr. Sangpa sir.
Yeah, I think he's rightly said, but in the present scenario, there are guidelines which vary from place to place, say for example from different states. But as a matter of fact, for a general guidelines would be if the patient is for emergency surgery and if she could wait for 48 hours, we must do the COVID testing. As a general policy, each and every patient is considered to be COVID positive, but we must do taking more precautions. All patients requiring surgery, we should do COVID testing before wherever they require admission. I am not sure about the policies which are required for daycare surgeries, say for example office procedures, whether they don't require admission to the hospital. So whether, because in currently in Maharashtra we have different policies and we have to be very sure about doing a COVID testing. But
so in short, you should do a COVID testing before you do any gynae surgery.
Niranjan, can I come in, please?
Yes, please.
I think the preoperative testing will essentially depend on two things. We are now addressing not only the major cities. I think we have 1,400 participants, and we would have participants from even smaller places. Now, there are three issues here. Number one, what is the prevalence of COVID in your area? Number one. Number two is going to be, what is the testing facility available in your place? There are many small towns where testing facility is just not available. And number three, how much is your state government or municipality allowing you to test? Now, if somebody asks whether
wait for the result to come, because sometimes
of course. Now, the other important question is it the right time to start laparoscopic surgeries and surgeries under GA? I would say no, because a massive amount of migration has happened in the country in the last 2 weeks. And we had 5 districts in West Bengal which were green, which had no cases. And all of them have reported cases in the last 7 days. So in the next 2 to 3 weeks, we would have to redefine what are your red zones and green zones.
Bhaskar, what we are talking is basically a gynae surgery. That's what Dr. Rajendra Sangpa is telling, that the policies change from each state to state and town to town and cities to city. What we are trying to give and convey the message to everyone, that if you are starting your OPD or if you are starting a gynae surgery, whether it is endoscopy in an emergency case, obviously Dr. Rajendra has very well said that he is only doing emergency cases, he is not doing routine endoscopic surgeries. If I am not mistaken, that's what you are saying. So it's better to do a test, and you continue to take precautions with yourself, that as if this patient is COVID positive.
Absolutely.
That is what is the take-home message.
Absolutely.
That is what is important.
Yes. Plus, elective surgeries try to defer by another 3 to 4 weeks. Those which can wait.
That will be decided.
I think Anaita wants to
Anaita, yes, please. Anaita, I want to hear from you.
especially in the larger metros like Mumbai and Delhi, where the numbers do not look to be going down over the next couple of weeks for sure. We have to do COVID tests the same way we would do HIV for all pre-op.
Absolutely.
So it has to be a part of the pre-operative testing.
So, madam, but the report comes after 3 days. It comes after 2 days.
Elective surgeries. Niranjan, we are talking about elective surgeries. And I
Yes.
ask her that elective surgeries, none of the large hospitals in Mumbai have yet given the diktat that we should start elective surgeries. So I think we are still a couple of weeks away from that.
No,
So I
even if
think
you
those
think-
who are in the green zone, those who are in orange zone, let's be specific, those who are in red zone, containment areas, containment zone, we should withhold it. But those who are in green zone, they
I'll give
surely
you,
are in orange.
I will, there is no green zone at the present moment. I'll tell you,
Okay.
Latur,
Start routine surgeries, elective surgeries, till situation was slightly better.
see, Latur had 0 cases. After the migration, Latur now has 120 cases. So the definition of green zone is changing. And that is why places like us or say Latur, which had started elective surgeries, I think we might need to watch the situation over the next 2 to 3 weeks. And if you have testing facilities available, please test. If you do not have testing facilities available, assume the patient is COVID positive.
Okay,
This
okay.
is for
okay.
emergencies.
Fine, I
and
think
severe.
everyone, Bhaskar, everyone has got the whole idea. There is Dr. Reena Shrestha. She is from Nepal, Kathmandu. Her question is to both of you, Anaita and Bhaskar. Can we rinse and reuse PPE?
So my point about reuse was only about the unsterile ones which we use in the OPD. Definitely you can soak it in a hypochlorite, dilute hypochlorite solution and then rinse it, hang it out to dry. But for the sterile ones, what Saifi Hospital is currently doing is that if the PPE is not being used in the operation theater, but it is being used on the floor, they are ETO sterilizing these. Of course, the quality, it will depend on the quality of the PPE, how thick it is, because some of them, when you pull the zipper, the whole PPE just comes apart. So if the quality is good, you may be able to ETO it for about 2 or 3 times.
Niranjan, please start your video. You are not seeing.
Okay, fine. Thank you.
Bhaskar, you wanted to add something to this?
No, I wanted to add means, I don't think that what sort of protection you will take depends on whether your city has got more cases or less cases. On one hand, while it is good to be overprotected, the reason that as a hospital we are not telling overprotection is because our data is based on 2 countries where healthcare transmission has been very low, that is Singapore and South Korea. And one of the issues is that more people get infected while doffing rather than putting on the PPE. So the more stuff that you don, you have to be extra careful how you are when you are doffing and how you are disposing them. And that is why it is, except on the COVID ward where we are extremely strict and we go with a 3-layer protection as opposed to the 2-layer protection that is given by WHO. On other settings, we've adopted the Singapore and South Korea model, and we've done pretty well. And that is one of the worries, is that if you don a full PPE, at one point of time we saw somebody wearing a PPE and walking across from one building to another, which is absolutely disastrous. But then biological waste disposal, etc., we do not want to infect people by a doffed PPE.
Okay. Dr. J.B. Sharma. Yes, Rajendra, you wanted to say one word?
I think not a one word actually, but people should know about, the very much about donning of PPE and doffing of, PPE is very important. That when you put on, normally you put on if you can allow me for 1 minute, I'll finish it in 1 minute. If you first you put on a scrub in the operation theater or a changing room, then secondly you put on the shoe cover, and after putting shoe cover, then you wash your hands, then put N95 mask. This has to be followed, and after N95 you put on a cap, then put on a surgical mask over the N95 mask, then wear goggles and then scrub, and then put on a gown, completely cover yourself, and then put on surgical double gloves. This is how you have to do donning. While doffing, you take out the clothes in one piece along with the 2 gloves, whatever you are using, and thereafter, without touching, you have to put the unsterile gloves, which are there in examination glove. remove your shoe cover, keep the rest of the, then you remove, after removing the shoe cover, do not, touch anywhere, just remove those gloves, wash your hands, sterilize those with the sanitizer, put on new gloves, then only remove goggles and the outside mask and the cap. This is how you must do the donning and doffing. Otherwise, there is likelihood, if you are touched or delivered a COVID patient or done a cesarean section, there's a risk more of getting infected during donning and doffing. So
I just want to add that in labor room, in the OT, and even in ICU, where you will require to don and doff, and many of us don't go there every day, it is impossible to remember that. So you need to have a flow chart which is put up in the donning area and doffing area. Foxy guideline has got a lovely picture, and I say that people can refer to that. And especially if you're using it once in a while, then it is useful to see a donning and doffing video, especially the doffing video. When you take your coverall down, you have to keep on rolling it so that you never touch the outside. And that, if you're wearing it so once a week or once in 2 weeks, doesn't come automatically. So we have to rely on flowcharts and videos repeatedly.
And you have to also have a staff to help you in this.
Yes.
And you have to make sure old people like me don't trip as you are doffing.
I think doffing is very important, and Dr. Rajendra Sangpan has told very nicely. Everyone has explained it very good. Dr. Reena Shrestha add, sir, if there is a suspected case, then if she comes to the OPD, are we supposed to send back her home after taking the test for COVID, and then we will admit her in the hospital till the report comes?
If you have a,
I think she has answered the question, right? She's right. Bhaskar, you want to say something?
But in a small clinics like standalone clinics, I think if you are suspecting COVID, it is better to not make them enter into the clinic and mingle with the patients. So we have to send to the testing areas. In each city, will be having some testing areas. There can be sent there and testing, unless it is emergency.
I think if you are practicing in a small nursing home, any patient who's got fever, cough, or shortness of breath, do not let the patient come into your facility. Tell them to please go to a fever OPD in a COVID hospital and let them take a call.
Yeah.
Absolutely. Yeah. So there has to be a person outside the reception. There has to be a person at the entrance of your OPD standing, like how you find in electrical store, hardware store, a person standing outside with the sanitizer, with a mask. So kindly make one person stand there, one employee, so that he is going to understand. And if possible, as Dr. Bhaskar said, to summarize, send such people to the fever OPD, not to take them even inside your clinic or in consulting rooms, because that can be very dangerous. So we have to be very careful. And Dr. Fessy Lewis has said a very important point. I want to hear from Dr. J.B. Sharma. Dr. J.B. Sharma, please unmute your mic. We have been waiting to hear from you. Please unmute your mic, and we have been waiting eagerly to hear from you. Yes, thank you, sir. Please join, sir.
I'm there, sir. I'm listening carefully. The beautifully illustrated by Dr. Fessy Lewis, Dr. Sangpal, Bhaskar Pal, Aneta Madam, and yourself. So everything has been really highlighted, and we are thankful to the viewers who are so carefully listening to everything. So I think, as someone was asking, probably these days, I think testing for COVID, just Dr. Anita has also said, is very mandatory. So unless it is an acute emergency case like ruptured uterus, ruptured ectopic, where you can take risk and take all
then
the
only
precautions.
you do.
Otherwise, we should, for elective cases, we should do the testing.
Now, sir, I want to ask you a very important question. There are women, most of them are coming with leukorrhea presently in our gynae OPD. Though it is a COVID times, but they are having itching, they are having vulval infection, they have issues about heat, and they have got pruritus, vaginal infection. So to treat them, what antibiotics you would like to give? Obviously for telephonic consultation, and I want to ask you whether you have to take pap smear in such cases. This is the question being asked by by Dr. Manjusha regarding pap smear for screening in COVID times.
Okay. No, sir, pap smear, I mean, can be taken, though we have, I mean, suspended most of the routine procedures, like all urogynec surgery we have stopped for the time being. So even pap smear can wait, but in case selected patients, I mean, you can take endometrial sampling, pap smear. There is no contraindication to do that. And I mean, I think this is the time when WHO recommended policy of syndromic management can be used. So that these
Yes.
patients can be given, like, what we used to have, that fluconazole, azithromycin,
So we have got the
secretazole,
green,
and
that yellow, that red packet,
absolutely
RTI, STI,
available.
clinics,
Absolutely.
etc. Yes, yes,
And
very good,
they
sir.
can be, this is the right time to use those kits, sir. And
Suraksha,
those testing
Suraksha
also we can
clinics.
use.
I think
Plus
you have got Suraksha
clindamycin and
clinics.
clotrimazole pessary, along with clindamycin, clotrimazole pessary. So they will take care of all chlamydia, mycoplasma, and candida plus PID also.
Very good, very good. Sir, Dr. Sangpar, there is a question by Dr. Ashok. He is asking whether you have negative pressure operation theatre and is it really required to operate on a COVID patient? Dr. Ashok. I think this Dr. Ashok is from the railways. Our famous Dr. Ashok Kumar from railways.
Yeah, it's a very pertinent question, but to whether the Indian Society of the Operation Theatre Management, it's called ESHRE or ESHRE, it's hospital heating, refrigeration, and ventilation. There is a society. They have put recommendation. There are certain recommendations based on international collaboration. Whether negative theatre would be, they said, keep negative pressure OT. What is negative pressure OT is normally all of us, when you have a AHU, which has been there in most of our hospitals, not in smaller nursing homes, but fortunately I have a AHU, air handling unit in my hospital. That is a positive pressure ventilation, where the air which is filtered comes from the blowers or the air handling unit inside the OT, and then it is circulated through the ventilator or the air curtains on the ground part of the operation theatre. It is sucked, so the pressure inside the theatre is more than the outside. So outside air doesn't enter into the operation theatre. Negative operation theatre means if you have an existing theatre, it is very difficult to convert it into the negative pressure OT. But they're saying you have to put fans inside the operation theatre. You put like a normal fan, like a pedestal fan in one particular window, and then you filter the inside OT outside. So you are draining away all the air outside the operation theatre, maintaining the theatre as a negative pressure. I'm not sure, because the recommendations which come from them is also there. They say you wait till another 3 or 4 months till changing your operation theatre. But negative pressure OT, by and large, worldwide, they thought probably it would help reduce the spread of the infection to healthcare workers. But if you have a positive pressure ventilatory OTs with all gadgets such as simple mask, filters, they cost around 150 rupees. The anesthesia filter called HEMS or HMSE filters. Those are basically, they are viral filters. They can filter virus, and they cost 150 to the hospital owner. So the MRP is 500 rupees. You can use it 1 to 3 to every patient. That also reduces transmission of infection to our healthcare workers as well as to your anesthesia machine. So as a laparoscopist, I use 2 filters for laparoscopy and 3 filters for protecting my equipment and anesthesia machine. So overall cost is around 700 rupees per patient, but it is worthwhile in my operation theatre to prevent transmission to my health workers as well as to my anesthesia machine and future patients.
Thank you. Dr. Anaita Chauhan, I am coming to you. There is a question by Dr. Kalpana Patrawala. She is from our MOGS society. Madam is asking for dilatation and curettage for menorrhagia and thickened endometrium. COVID test should be done.
I think for any procedure where you are at risk and the patient is entering an operation theater, the COVID test should be done. This is also the time I would like to emphasize that we are going to have to change our practice and look at medical management of so many conditions where we first used to jump for surgery. So we have to weigh the pros and the cons. If she feels that a dilatation and curettage is essential and is the only option for that patient, and she wants to take the patient into her operation theater, do the COVID test, make sure that she is well covered, especially because this is the time she can have the splashes on her face shield or her goggles, and go ahead.
And I also agree with you, madam. And maybe we need to, does she really need DNC?
Exactly
at
my
this
point.
time?
This
Can
is
we
the
give a
point we
progestogen?
have
I mean,
to change our practice.
unless you are suspecting endometrial carcinoma, I feel we can give her progestogen or tranexamic acid.
Medical
So
treatment.
medical management will come into play now. Medical abortions will be into play now.
Absolutely.
So there are many questions, but it is wonderful to hear from you, Dr. Chirag Amin. He is asking, should we avoid using HEPA laminar airflow? Do you use a positive pressure laminar flow in COVID era? Dr. Rajendra, Dr. Bhaskar, can you please unmute?
I think, but still, there are guidelines are not very clear. Everybody is confused. Somebody has mentioned about negative pressure OT, and negative pressure OTs are not, available everywhere. And even in smaller places, people are using only the split ACs inside the operating theater room, which we are not supposed to use it, because it doesn't.
So are we supposed to use the air conditioning system during the operation theater?
Absolutely. Air condition reduces the temperature and reduces any growth of any bacteria. So it is mandatory. Your theater humidity has to be managed to 55%, but you cannot have a very warm theater. That will increase the growth of any bacteria or viruses. That is true. Whether negative pressure or a positive pressure, yes, because it is already your operation theater is protected by reducing viral load, of a circulating air. Negative pressure is an additional advantage. I'm not sure whether you should convert. You wait for another 3 months till the guidelines will get.
I think we should not talk of a negative pressure OT at the present moment, because it is more of a theoretical concept. Whole of city of Calcutta has got only one negative pressure theater. Most of the operation theaters abroad are not a negative pressure theater. Not only negative, it will be a huge cost to convert your negative theaters into negative pressure theaters, because it gets too warm. It is difficult to operate, and for all other COVID negative cases, the infection rates would go up. So the issue is that it is important that if you have an air handling unit, to understand that what is the air cycle with your air handling unit. So essentially, speak to the engineers who installed the air handling units, and they will tell you that what is the two important points, that how frequent is your air change, and number two, with each air change, what percentage of fresh air is blown in. Now, please remember that this is a respiratory virus. As Tracy said, we do not know a lot of things, but gradually it is getting clearer that you get infected by inhaling the virus or rather than touching the virus. So touch is going to be less of an issue. The point is the aerosols that are generated. For example, we have theaters where we have approximately 12 air changes per cycle. In 12 air changes in essentially in an hour, and with every change, 20% fresh air is blown off. So change. So what happens is that, which means that during GA or during intubation or extubation, the aerosols that are generated, it will approximately take 15 minutes to be taken away, the entire air to get changed. So our anesthetists have advised that surgeons, if it is not an emergency, enter the OT 20 minutes after the patient has been intubated. I mean, similarly, during extubation, apart from the anesthetist, nobody else would be there, and only after the surgeon would leave before that, and the cleaning people and etc. will enter the OT only 20 minutes after the extubation.
I think please remember, all of you, these points have been very nicely explained by Dr. Bhaskar Pal, how you are supposed to be and what time you are supposed to be inside the OT, after the anesthesia, during intubation, after extubation, when and how only anesthetist has to be there alone while extubation. So all these things you will have to follow. Now there are two questions which have been asked to all of you, Dr. Vanita Shetty and Dr. Asthagi Ambaraya. Dr. Vanita Shetty says that any doctor who is above 70 years and Asthagi above 65 years with comorbidities, should they start general practice or gynae procedures or gynae OPDs? Please. I think everyone is in affirmation in one voice. Yes, Anaita?
No, sir.
No, I don't think so.
They should not, sir.
They should
At
not.
least during the
Please.
COVID.
Should not.
I think even
Please do not.
Maharashtra Medical Council has exempt those over 55. And I think what the lesson to learn from the UK, etc., where senior doctors reported to work initially, is that if you are old and you have a comorbidity, you are not a doctor or a patient, you are going to suffer. So I think we should not have a hero complex. At the same time, we should also make sure that we set an example for our juniors. Because I'm seeing a lot of juniors very reluctant to work. My mother is not allowing me to go. My mother-in-law is not allowing me to go to the hospital. So we have to encourage our juniors that by setting an example. At the same time,
I want to tell you, Dr. Anaita Chauhan was the professor in Department of Obstetrics in St. GS Medical College. She has a teaching experience of up to more than 20 years. After that, she has joined Saifi Hospital.
I think we all have to strike our own balance. At the same time, we have to think about personal, professional, and society. And I guess it's at the end of the day a matter of conscience as well. So though we may applaud somebody at 70 who's going back to work, I don't think it's a risk that's worth taking.
I think Dr. Vasanthi and Dr.
I think Niranjan, I think
Asthagi.
on top of that, there are some specialties which are at higher risk. Please understand that those who are doing on the COVID duty, because they are well protected, they get less infected than general physicians who are looking at fever and cough, ENT specialist, ophthalmologist who go very close, ENT, gastroenterologist, and dental. So these are the people, if you are above 65, you are better off staying at home.
I would like to tell all of you, our trustee, Dr. Adi Dastur, sir, is watching live with us. He just called up 1 hour back and told Niranjan, I am joining this program to see you. There are many webinars, so we are very thankful to him to join us. Welcome, sir.
Convey our regards to him. Such a senior person. Yeah.
Give us regards to sir.
Yes, he's a very senior professor from Wadia Maternity and MOGS President, Foxy Vice President, Chairman, and he is presently our trustee. So
Past editor of the Indian Journal.
Yes, and editor of the journal. And I hope, sir, if you are hearing us, we are very happy to see you. Shat Koti Pranam from all of us, Dr. Adi Dastur, sir. Thank you so much. Dr. Rajendra, Dr. Fatima doesn't want to leave you. Fatima Shiba, I think she's from Bangladesh. Dr. Rajendra, how to retrieve the specimen? The uterus in a TLH through the vagina. Now, Dr. Rajendra, you will have to take her a special class and a clinic for her. Can you briefly tell us?
In short, I would say in this COVID pandemic, when you are retrieving any specimen, it is a cause of concern. Whether, as I mentioned earlier, if you are removing the specimen of uterus, first you have to aspirate all the pneumoperitoneum. What I mean to say aspirate means earlier we used to just open the wall of the trocar cannula and let the air go in the operation theatre. But today it's not the time. We should avoid, we just apply suction tubing to the trocar and deflate the abdomen and then try to pull the specimen from below and remove by, if it is simply it comes, if it is bulky uterus, then coring technique, that we learned in our gynecology, coring technique. Once the specimen is removed, block the outlet of the vagina, then inflate the abdomen and then suture the vagina. If you can suture the vagina from below, that is also fine. But if you want to suture it from above, then a vaginal outlet has to be blocked. Specimen retrieval is really a critical aspect of laparoscopy during pandemic, because the moment you try to remove the specimen through the bag inside from the abdomen. Bag has to be inserted into the abdomen when the abdomen is inflated. With inflated abdomen, we are not putting any larger size thing like such as a bag. It is going to have a loss of pneumoperitoneum and spread of potential virus into the atmosphere. So it is
Sir, I can tell you, since the question answer has started, there are 1,500, more than 1,500 members logged in. I'm just getting questions. Dr. Kalyan Barmade just written about to start routine work. I think Dr. Bhaskar mentioned about Latur also. What should be done in cities when COVID testing is available?
That information has been provided to me by Dr. Kalyan Barmade. Please tell him.
Okay. Thank you. So where the COVID testing is available in only government setup and only government IPD patients are tested. This is what Dr. Kalyan has written. Dr. Fessy, I am returning to you. There is one question regarding IVF from Dr. Srimant Burute. What precautions to be taken to prevent IVF tissue culture lab from COVID contamination? What precautions will you take for this IVF tissue culture lab from COVID contamination?
Actually, it is a droplet infection. So till now, the available data on it is not seen in the oocyte fluid or from the semen, and also not in the oocytes and embryos. So I think right now the routine precautions what we take for all HIV and HPSAG positive patients will be enough. So we have to handle with utmost care. No additional thing is be needed for COVID for all the routine patients. And routinely, if you are screening for COVID, if the prevalence is very high in your area, definitely there is no additional requirement is needed. But if it is a positive case, then we have to, if the embryos, we have done the oocyte pickup and afterwards it comes positive, then we must freeze in a separate container, separate for COVID patients. That is what is recommended, and we must not transfer those embryos in those patients. That is in a very few patients only that conditions will arise.
Thank you so much. There are many questions. I think you have already answered. Better to do under regional anesthesia, spinal or epidural rather than GA. Absolutely. If you are doing a surgery. And we have got many questions here. Can N95 mask be washed and reused? Prema Rajendran, Dr. Anaita or JB Sharma?
Ideally, we must not do that.
I would tell JB Sharma, because we are all following the AIMS reuse policy. So JB, if you can tell us the rationale behind it.
Sir, what has been done for us? They have provided us a pack of 5 and masks. So we wear that Monday 1st, Tuesday 2nd, Wednesday 3rd, Thursday, Friday, like that. And then again we repeat the Monday one again on Saturday. So the turn of that mask will come on 6th day. So by that time, hopefully all the virus will be gone. So that we continued with that. Almost it lasted for 20-25 days, and now we have been given, yesterday only we have been given a second pack of 5 masks. So that is it, and but there have been some people who are reusing them, but probably not for doctors, sir. Maybe like in our apartments, non-medical people, they can wash and reuse because they are not at high risk. But for doctors like we people, we have to use a proper mask, and we shouldn't wash it. We should use a proper N95 mask. But we can, like what we are doing in AIMS, reuse it after 6th day. By that time, it is negative use. Maybe Dr. Sankpal can.
Okay. Yeah, I think, at Hinduja Hospital, what we do is the packet when we open, we keep the outside cover, written our name. We write our name on that. And while going out of the OT, we put the mask again inside the same packet and give it to the the in charge, whoever is there, and they do a sterilization by hydrogen peroxide, that is Sterad. We have Sterad at this thing, and they also can be ETO sterilized if it is available. So that is what we have been doing. When we are going for the next time the surgery, same mask will come. So that is one. But I don't think so, as sir said, that it is not to be washed. for doctors and healthcare workers who are exposed to more amount of virus.
Rajendra, I just want to ask, are you using the routine face shield which is been, because that will reduces the, even if you're using the mask,
Yes.
the chance of you touching your eyes, everything will come down.
Yeah, we are using face shield. Well, earlier I used the face shield which available for 60 rupees. But what I have realized in my practice is that when you are already scrubbed and sterile, it keeps touching your hands, you know. So now we have another this thing face shield which is made by this helmet guys called Stud, and it is very it is approximately 250 rupees which I got it for. It's very nice, doesn't fog, and very protective.
Here, no, that same bike shield that costs nearly 600 rupees. More than that, some people are telling it is little more, suffocating to use for longer period.
Yeah.
But the problem with that OSP face shield is, if it is cheap, but you have to keep it little low down, otherwise it keeps touching your hand.
Yeah, exactly. That is the problem. If you using
Can I say something?
it's not that easy. Yes, please.
Anaita, yes, Anaita.
Yeah, so the cheaper face shields have a lot of distortion because the quality is not good. So those are good only for OPD or other interactions with patients, and they are not good in the theater. In the theater, either you wear the goggles, and for people like me who have glasses, I have got like literally biker type goggles which have silicone so that the fogging is reduced, because the other shields cause a lot of fogging. Even if you use the Stud where this face part is firm, there's still a lot of fogging.
That is having more fogging because of the closeness to your
part
face.
of the shield keeps hitting your hands as you're working. So it's better to use something which sits more snugly, and make sure that the seal is very tight on your N95 so that the fogging is reduced.
Correct.
I just want to come back to the N95 issue. Please know that the CDC has tried 3 testing methods of dry heat and also ultra UV and etc. But for a country like us, the AIMS technique is possibly the most user friendly. We are given a set of 4 N95s in 4 envelopes. On each envelope, we write our name and write 1, 2, 3, 4, 5. We use mask number 1 on day 1, mask number 2 on day 2, mask number 3 on day 4, and on day 5 we again use mask number 1. Once we finished 5 usage of all 4, all 4 are changed. If any mask gets soiled, then it is automatically changed.
Same we do in
Thank you.
AIMS.
Thank you so much. In Varanasi, there is only one center, BHU, where COVID-19 testing is done. So for any type of surgery, we are unable to test. That's what Dr. Sangeeta Roy writes. Dr. Samir Pradhan is saying that can we restart elective gynae's work under regional anesthesia and COVID negative patients using universally precautions? Dr. Samir Pradhan, Dr. Anaita, can you answer that?
I would say currently, with a little bit of relaxation which has started now, there is likely to be a spike in cases, because now the community spread is gone crazy in Bombay. I would say wait for at least another 2 weeks before planning routine surgeries.
There is
err on the side of caution.
Thank you, Dr. Anaita, for that absolute necessary message that wait for some time, at least for the routine gynec surgeries. Yes, you can start your OPDs, all of you agree, but take precaution. There is a very interesting question and I want to share with you. Dr. Jayashri Bidkar is saying, if you ask for a pre-op COVID testing of patient before surgery, patient may also demand testing of the operating surgeon and nursing staff. Should the hospital staff and doctors also get their COVID testing done before the surgery?
I know it is a really interesting question, but in the present pandemic, with the governments and state norms and the municipal norms, you are not supposed to test if you are asymptomatic. So that's very clear that we cannot test when you are not symptomatic.
No, there is an additional problem of testing. How often do you go on testing a healthcare worker? Do you test them daily? Yes, we have mad people sitting at White House who are testing their staff daily. All staff who get within 6 feet of Donald Trump are tested daily. Obviously, we can't do that. So while this remains a theoretical question, but this is not so funny, because I know one hospital in London where the obstetricians, two of them are tested that week, and that week they are put on only for non-COVID patients. And so it does happen. But I guess this question will get answered when we get antibody testing. And a time would come when we will demonstrable IgG levels, we will tell us that, okay, there's nothing to worry from us.
So there are a couple of larger hospitals in Bombay where their staff is initially was tested every week and now is tested every 14 days. But I don't see the rationale of that, because you're burdening a system which is not able to cope at the present moment.
So thank you, Dr. Bhaskar and Dr. Anayata. In government hospital where every day 30 plus cesarean sections are done and there is no adequate testing facility and PPE, how do we save ourselves? Dr. Anirban. Dr. Anirban, don't worry. You have to use PPE. You have to use adequate testing. Please talk to your dean or your superiors. I'm sure there are donations being done from other organizations, and there are many people who are here to help you. I'm sure whoever is hearing will surely understand Dr. Anirban's plight, and we are going to help him as how many as possible PPs we can send him.
One thing I want to add is that regarding that previous question about doctor being tested like that, the consent is important, not the routine consent. We must take a special COVID consent, and for all procedures, that not only the patient, even if it is negative, can get the infection afterwards also. So that special consent is needed whenever, whatever the procedures you are undertaking for at present. That is additional consent you must take for medical legal aspect.
Okay, Dr. Sharmishta Ganguly is asking, what do you mean by GSM? Dr. Bhaskar, just tell us briefly what is GSM.
Can't hear you.
One should not look at GSM. I think a lot of what is happening is a lot of textile manufacturers are coming out and saying that my product is better because it is 90 GSM, or my product is
so minimum GSM should be how much, Bhaskar?
There should not be any minimum GSM. There are PPs that you are getting between 60 to 90, even 100 GSM. Now, GSM only gives you the thickness of the material. What the government of India has done, that the government of India has given that your specification of PPE, that it has to be certified by DRD or CITRA. And what they look at is your resistance to chemicals and resistance to liquid spillage. And I think there is something called ISSR3 or something certification, which looks at what is the toughness of that. GSM only gives you the thickness. Please remember, the higher is the GSM, more is the thickness, and less breathable is going to be. So you might get an adequate protection if it is certified with 60 GSM rather than going for 90 GSM. So don't bother about the GSM.
And also the cost. Of course, the cost.
Yeah.
So the costs are there.
They're pushing up the cost by increasing the GSM.
So GSM is grams per square meter.
Yes.
And where the GSM is thicker the fabric. So that is just a technically, by everything rest, Bhaskar has
Dr. Rajendra Sagpal, thank you very much. You immediately went on Google and you found out the right answer. And Dr. Bhaskar Pal, you were very nice enough to tell us the permissions from where we get, and then minimum 60 is fine. Dr. JB Sharma, I heard Dr. Guleria yesterday on TV news regarding AIMS, regarding Safdarjung hospitals, how they are managing, how they are doing biomedical waste. And there is a quality control team in AIMS, and they are seeing all the PPs, all the N95 masks. They have also sent them back if they do not come up to the optimum level of approval, and that's what I heard from Dr. Guleria. Dr. JB Sharma, you can say something on this issue, and then we will wind up this program.
Yes, sir. Thank you. I think we need to start sooner or later OPD, but as we need to go gradually, as Dr. Anayata said, and we must not compromise about quality. So N95 masks have to be used, and preferably, I mean, for healthcare providers, there should be new ones, or I mean, not washed or anything. and then we should take all the necessary precautions, and we should go slow on the routine OPDs, routine OTs, and that can be suspended. But like sometimes like a big ovarian cyst and a little bit doubt of torsion, that can be done definitely, and a simple D&C other procedure can wait for 3-4 weeks, and that's all. So I think, but we should not be scared. Take all precautions. But thank you very much. It was a real pleasure to come here. Thank you, sir.
Niranjan, I just to answer to Sharmishta's question, I have it in front of me. It is a ISO 16603 class 3 exposure pressure or equivalent. That is what is looked by. That is the ISO 16603 class 3 pressure means that is a certain level of permeability against liquids and chemicals, and that is what the DRD or CITRA tests for.
Thank you. Thank you all of you, Dr. Pesi, Dr. Rajendra, Dr. Bhaskar Pal, Dr. JB Sharma, Dr. Anayata Chauhan. You have been so nice and wonderful.
And Dr. Niranjan Chauhan.
Thank you, Niranjan, of course.
Niranjan, you have done us
Definitely, Dr. Niranjan.
Hi,
You
everybody.
did very well. I mean, really, you are the way you conduct is beyond comparison. And
Phenomenal.
Everybody, attentive, make them compulsory attentive towards the screen. So thank you.
I want to say one thing, that all of us will have to, as we grow older, look at alternate professions or alternate sources of income. And I think Niranjan has found his niche.
Yeah. Thank you, all of you. Before we go, I want to, all of you to introspect. While as doctors, we need to look at various aspects. We are going through a lot of turbulent times. Our patients are also going through the same thing. I have a poem for all of you. I would like to read it now. And that's what the nation wants to hear. खूबियां और खामियां सब में होती है, खूबियां और खामियां सब में होती है. कुछ लोग अपनी खामियों के साथ भी इंसान सही होते हैं, और कुछ के अपनी खूबियों के साथ भी इंसानी गलत होते हैं. So with this poem, हम सभी कोशिश करके पहले वाले लोगों के जैसे ही हो. So there are two types of people, as this poem says. There are खूबिया and खामिया. So let us be with that one खामी. एक गलती, एक ऐब नहीं, पूरा पैकेज बेहतर होना चाहिए. And that's what we do when we plan a webinar with TOG. And we plan, we prioritize, we produce the best each time to be better than the earlier. And you all are part of this journey. Such a wonderful panelist I have got, and the audience today. Thank you, India, for being there with us. Thank you, Bangladesh. Thank you, Nepal. Shabba khair. Take care. Swasth raho, surakshit raho, and be safe. We will catch up with you soon. Thank you so much.